Hi guys. So we're going to talk about part 2, which is respiratory physiology, specifically the mechanisms of breathing. This is called pulmonary ventilation, and it consists of 2 phases. The first phase is what's known as inspiration. The second phase is expiration. Does anybody know what inspiration is? I would be right if you said gas flows into the lungs. You can think in. Expiration, then, if you're thinking ex or as exit, it means that the gases exit the lungs. So that's inspiration and expiration. Now, when we talk about how air flows and breathing, basically air flows through the lungs due to pressure. And pressure relationships are very important in this process. And so we have what's known as atmospheric pressure, which is PATM. And this is the pressure exerted by what? By the air that's surrounding the body. And it's essentially 116 millimeters of mercury at sea level, which is about 1 atm. Now, when we describe respiratory pressures, we describe it relative to the atmospheric pressure, or this PATM. So if we talk about there being a negative respiratory pressure, essentially that just means that it is less than that PATM. If we're talking about there being a positive respiratory pressure, and I'm just going to put RP for that, then essentially we're talking about it being greater than PATM. And when we're talking about there being zero respiratory pressure, it means that it's equal, that the respiratory pressure is equal to the atmospheric pressure. Now, so that's if you're talking about the air surrounding the body. Now, the next pressure we could talk about, it's called the intrapulmonary pressure, or the intra-alveolar pressure, which is PPUL. And this is the pressure where, do you think? In the alveoli. This pressure eventually equals out with ATP, and this basically fluctuates with breathing. In the intrapleural pressure, or PIP, is the pressure where, do you think? This is a pressure in pleural cavity. So this again fluctuates with breath, and it's always a negative pressure, which since it's always a negative pressure, it essentially does mean that it's less pressure than PATM and less pressure than PPUL. And it's normally by 4 millimeters of mercury less, right? And the pleural cavity has liquid in it, right? So the liquid needs to be kept at a minimum. If it's not, if you have too much or excess fluid pumped out by the lymphatic system, the fluid can accumulate, making it a positive IP, and then making it so that your lung collapses. We don't want that. Now, when we're talking about breathing overall, there are two forces that promote lung collapse so that you can basically breathe. And there's one force that tends to force the lungs to enlarge. So the two forces basically, you have the lungs' natural ability to recoil. So the lungs are very elastic, so lungs always try to assume the smallest size. So this is one force that kind of promotes that. The second force is essentially surface tension. Of that alveolar fluid. And so the surface tension tends to pull on the alveoli to try to reduce their size as well. Now, this would make you think that essentially they would just collapse and remain small. But there's one outward force that tends to enlarge lungs. And it's this idea that you have elasticity of your chest. And that pulls the thorax outward. So from here, you end up getting that negative PIP, or PIP if you want to call it, right? Because you get the contraction of the diaphragm and those external muscles. And that essentially creates more room. And so you have more room there, but at the same time, if you remember, you have this adhesion force between the parietal and the pleural visceral pleura. So that's essentially being pulled out, right? So less pleural cavity pressure, you would think that it would collapse, but the strong adhesion of this, those serous membranes and the contraction of the muscle increases the tidal volume, or the amount of air that comes in and out of the lungs, so you don't have this collapse, right? So let me see. Let me go P and P. Pleura. Adhesion forces. So that talks about the three main pressures. Now, we can talk about transpulmonary pressure, which is essentially the P pull minus the P ip. So you're looking at, when we're talking about this one, you're looking at the pressure in the alveoli minus the pressure in the pleural cavity. And this is the pressure, this overall, right? This is a pressure that does what? Well, it keeps the lung spaces open. keeps lung spaces open. A, basically, it keeps it from collapsing. Greater transpulmonary pressure, the larger the lungs will be. The lungs essentially will collapse if the P-IP or the pressure of the pleural cavity equals P-pull, which is the pressure in the alveoli or alveoli, or if P-IP equals PATM, right? And normally, these guys here, the P-pull and the PATM, tend to be about the same. So if the pleural cavity equals the atmospheric pressure, right? Negative P-IP must be maintained to keep the lungs inflated. And like I said, it's normally about 4 millimeters of mercury less. And so this just kind of gives us an idea of what it looks like, right? And so here you have the atmospheric pressure coming in here. So this is going to be the same as outside. And this moves initially, it's not the same, but it ends up equalizing out. So this interpulmonary that comes down here, you notice it's 0 because it's the same as the atmospheric. And what's different is this ends up being about 4 less here, and that's going to in that pleural cavity. And so this is going to allow breathing to happen and there not to be a collapse of the lungs. Now, you can have a collapse of the lungs, and when this happens, it can be due to a couple different things.
When you breathe, air travels through your nose, down the trachea, and into smaller airways called bronchi. Bronchi branch into smaller passages called bronchioles, and finally into tiny, thin, fragile, grape-like sacs called alveoli. Sometimes the bronchi and bronchioles can become obstructed and block airflow. This can cause all or part of the lungs to collapse, a condition called atelectasis. There are several different causes of blockage: a foreign body in the air passages, pressure from chest tumors, trapped sputum or mucus, or other lung disorders. Atelectasis can develop as a consequence of surgery where intubation was needed. The first step in treating atelectasis is to remove the cause of the obstruction. Supplemental oxygen, chest physiotherapy, and antibiotics are also used as standard therapy. In most cases, the lung tissue will return to normal.
So as you can see, atelectasis is lung collapse due to either a bronchiole being plugged somehow, that normally some kind of obstruction, whether it be something in there or, or cancer cells, tumor, something like that. Now, pneumothorax are actually when you get air in the pleural cavity itself.
During normal respiration, the lungs expand and contract within the chest cavity. The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters the space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. A spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called blebs can form on the lungs. If the blebs rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and in men between the ages of 20 and 40. A tension pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
So that's a pneumothorax. And so that is when you get air in the pleural cavity. And it can be from a wound, if in the outside or the parietal pleural, or rupture from the visceral pleural. And it's treated by removing the air from the chest cavity. And then when the pleural heals, the lungs will reinflate. And so this kind of shows you the two. So if it's an external wound, it goes through the parietal pleural. And that means, before, remember this was at -4, but if you remember, we talked about if this P-pool ends up equaling the P-ip, which happens here, right? Then it's going to collapse. And so this can come from this is from the outside, and then this, if there's a spontaneous rupture on the inside, then again, that same thing happens. This -4 becomes 0, and your lungs are going to deflate. Now, when we talk about pulmonary ventilation, it consists of inspiration and expiration. And the mechanical process that depends on volume changes in the thorax basically leaves how this works is volume changes lead to pressure changes. And then basically pressure changes lead to the flow of gas to equalize pressure. Equalize pressure. So Boyd's law is this relationship between pressure and volume of gas. And basically, mathematically, this is P1 V1 equals P2 V2. And so pressure varies inversely with volume here, right? And so if the gas, what this is saying is if the gas, the amount of gas remains the same, and the container size is reduced, what will happen to the pressure? If you said increase, then you would be right. So on inspiration, when we're allowing that gas to go in, this is very much an active process, okay? And you're having the diaphragm and the external intercostals help. So when you have two things that are helping with inspiration. You're having action of the diaphragm and action of the intercostal muscles. And what's happening there is the diaphragm is actually contracting. And this dome-shaped apparatus actually moves down and flattens out. The intercostal muscles also contract, and these are the ones that you find on the rib cage, right? And these essentially lift up and out. So basically, both of these guys, due to their action, results in an increase in thoracic volume. So as this thoracic volume increases, lungs are stretched, right? And so they're pulled with the thoracic cage. The diaphragm opens up areas down at the bottom, right? So that essentially you are getting more room. Now, this process right here, as the lungs stretch, actually cause the, for a moment, the pressure to drop. So essentially what we're doing here is P-pull is going to end up being, for a short period of time, less than P-ATM. So the pressure in the alveoli is less than the pressure outside. Because of this pressure, the air will flow into the lungs. And so air will flow down. Let me do this. And air keeps flowing until P-pull is equal to P-ATM. And so that's how breathing essentially works. You do have forced deep inspiration that it can occur during vigorous exercise or with people with COP. And that essentially will help to increase, or how that works is you get accessory muscles to help. To make the cage even bigger, right? Take that out. Make cage or thoracic region bigger, right? So you have things like the scalenes, the sternocleidomastoids, the pectoralis minor, or the erector spinae, which are, if you remember, all the back muscles. And that essentially will help to further increase the thoracic size, creating larger pressure gradients and a movement of more air, right? So things, sternocleidomastoid, right? Pectoralis minor. And even the erector spina, all of these, and then the sternocleidomastoid, right, and the scalenes. So all of this essentially helps us to breathe deeper. Now, if we talk about the process of how we inspire, we're going to end up having to talk about the process of how we expire. So really quick, you could see the different steps here, right? First, inspiratory muscles contract. So if you see, this diaphragm is going to move down, it's going to contract and move down. These ribs are going to lift up and out, and that's going to increase the volume of the rib cage. Because of that increase, the lungs stretch, and so your intrapulmonary volume increases. Because that volume increases, the pressure falls. And then gas is going to flow in to the lungs until the P pull equals PATM, right? And you can see here, basically with the change in the diameter, you're going to get the pull from the ribs to increase this rib cage around here. And then you increase at the bottom with the diaphragm. Instead of being like this, it flattens out. Now, expiration, and this is quiet expiration as normal. This is not any kind of where you're pushing it out. So this is considered a passive process because basically your muscles are just reacting. So the thoracic cavity volume decreases, goes back to where it normally is, and then the lungs recoil, right? So here the P pull is increasing by 1 millimeters of mercury, right? And so here, P pull ends up being greater than PATM. So air flows out. And basically it keeps flowing out till P pull equals PATM. Now, forced expiration is different. This is an active process because you're pushing farther then. So the process that basically uses additional muscles. So you're using the oblique muscles and the transverse abdominal muscles, as well as your internal. Earlier we were doing external, right? But now we're also using the internal intercostal. So this is when you're actually trying to, like, if you think about when you lift things or anything else, you can actually, or if you're trying to actually blow out a birthday cake or candles on a birthday cake, this is where you're actually using additional muscles besides just the rib cage or the external intercostal muscles and the diaphragm. Okay, so this is a little different here. And so just to reiterate the whole process, when you go to breathe in, remember your inspiratory muscles, so the diaphragm goes from diaphragm contracts and the diaphragm actually comes down. The rib cages rise up and go out, which increases the volume. The lungs are then stretched and the interpulmonary pressure actually drops by -1 millimolar of mercury. And so that allows air to come in, and air will go down its pressure gradient until P pull equals PATM. And so that's inspiration. Expiration, essentially what happens is your muscles, your inspiratory muscle, as your diaphragm relaxes, right? Here we had contracts. Here they relax, so this goes dome-wise. These go back down and in. So it's going to reduce the volume of the cavity. And because essentially you have the same amount of air in there, right? But the cavity is getting smaller, so that's going to increase the pressure. Remember we talked about that a minute ago when we were talking essentially about Boyle's law, right? And so this is going to increase the pressure, and then air is going to start being pushed out, and that's going to happen until your P pull then equalizes out to your PATM. And you can see this is the volume of the cavity or a thoracic cage when it's all contracting, and you can see this is the volume when it's relaxed. So it gets much smaller. So that's the process of inspiration and expiration.
Mechanics of breathing. Consciously take a breath and think about the fact that there are 10 different muscle groups working together to make this happen. These muscle groups include the diaphragm and intercostal muscles. The main muscle used for breathing is the diaphragm. The diaphragm is a dome-shaped structure consisting of several large muscles, which is sandwiched between the chest cavity, containing the lungs and the rib cage, and the abdomen, containing the digestive system, including your stomach. The muscles that move the rib cage itself are the internal and external intercostal muscles. They are each attached to the ribs and run between them. To inhale air, the diaphragm contracts and moves down, while the external intercostal muscles contract, forcing the rib cage up and out. The combined effect of the diaphragm and intercostal muscles increases the volume of the chest cavity and expands the lungs. This expansion of the lungs increases their volume, reducing the pressure within them, causing air to be drawn in. This action is similar to a piston sucking petrol into a car engine. In normal breathing, we use around 25% of our lung capacity, which is called our tidal volume. As you inhale deeply, the diaphragm moves further down into the abdomen, pushing your belly out, giving more room for the lungs to expand and draw in more air. This type of breathing is called belly breathing or abdominal breathing and is critical to prepare you for your free dive. Belly breathing allows you to completely fill your lungs with air. The maximum amount of air your lungs can hold is called your total lung capacity. With training, you can use more of your lung capacity.
So that's essentially inspiration and expiration. And then you can just look at how the pressures go to allow air to flow in. So the pressure on this first one is the intrapulmonary pressure, right? So this is inside the lungs. So when you're taking in a breath, it basically decreases till you get it equal. So air is flowing in, right? And then essentially it stops at the beginning. And then it increases here, +1, right? This is -1. And that's going to force air back out. And the intrapleural cavity, you can see here that essentially it starts at -4 because we don't want the lungs to collapse, and then it increases a little bit and goes back. And that's why you see the large volume of breath happening at the top, because that's the moment for which air is not going to be moving due to pressures. So there are a lot of processes that can move air into or out of the lungs besides just natural breathing. And they may modify normal respiratory rhythm. So most of these result from what are known as reflex actions, though some are voluntary, right? And so examples of this are things like coughing or sneezing. Right? These are both more reflex actions. Crying, laughing, hiccups, know those, and yawns. So these are all examples of how air can move without just natural breathing. And so I'm going to leave here, and this is going to be the next video. Hope that helped.